now. And I'd like to turn the floor over to Dr. Newcomer.
Thanks, Patrick. Good afternoon, everybody. And hello, Juthika. Before I introduce Juthika, I just have been asked to make an announcement about next week's seminar. So next week, the speaker is Tony Banbury. So Tony Banbury is a former UN Undersecretary General and head of UNMEER. Tony designed and led the UN's first ever emergency health mission in response to the 2014 West Africa Ebola crisis, among his many other accomplishments. His talk at this time next Monday is titled Lessons from the 2014 Ebola Crisis and What's Missing from the International Response to the COVID Pandemic. So that's next week, but for now, I am really delighted to introduce today's speaker, Juthika Thaker. Juthika is a doctoral candidate here at the School of Public and Community Health Sciences. I've had the great pleasure of working very closely with Juthika over the past few years as her dissertation and research advisor, and Juthika has become a really integral member of our research team here that we call Team Vaccine. So Juthika holds a Master's of Health Administration degree from the University of Missouri, and she also holds a Bachelor's of Dental Surgery from India. And I think Juthika's really unique background, both as a medical and dental care provider, and her knowledge of health policy and administration has been really crucial as she's developed independent research focused around immunization services delivery. And what she'll be talking about today is her dissertation work on adolescent HPV, human papillomavirus vaccination in Montana. And I just want to make a note that Juthika recently earned a prestigious fellowship, the CEASP Fellowship. CEASP is Cancer Education and Epidemiology in Special Populations. It is a fellowship from funded by the National Cancer Institute of the National Institute of Health. As part of this fellowship, Juthika is getting a scholarship for the research that she'll be doing this summer, and she'll be talking about some of that research today. She'll also get to go to a CEASP annual meeting in New York City, funded by the fellowship, where she'll get to present on her results and meet with other CEASP fellows. So really proud of Juthika. She was selected in a cohort of 19 this year from over 81 applicants. And just a testament to Juthika's discipline and all the work that she's done on this dissertation. She applied for this funding last year, didn't get it. But I think with her dissertation being further along and really well developed in the hard work she's put in, I think this year, she was very well deserving of this honor. So with that, let me turn it over to Juthika, and we're looking forward to this research update today.
Thank you, Dr. Newcomer. Do you hear me all right? Okay. First off, I wanted to start by wishing you all on the National Public Health Week. Keep doing the good work that you all are doing. My name is Juthika, and I'm a PhD candidate, as Dr. Newcomer mentioned. Today, I'll be presenting on my dissertation research, which is engaging nurses in promoting human papillomavirus vaccination in Montana. Okay. Just give me a moment. I don't know why these slides are not advancing. Okay, so the agenda for my talk today is that I'm going to start off by talking very briefly about the prevalence of HPV associated infections in the United States, followed by the HPV vaccine. I'll also talk about how these HPV vaccine uptake rates look like both nationally and locally in Montana, and then give you a high-level overview of my research aims 1, 2, and 3. So genital human papillomavirus infection is the most common sexually transmitted disease in the United States, with about 13 million new cases emerging every year. 50% of all these new cases occur in the highest risk group of 15 to 24-year-olds. Approximately 35,800 anogenital and oropharyngeal cancers that are diagnosed every year in the United States are HPV associated, and we spend about $1.7 billion every year just to treat HPV-related genital infections. So to protect against these HPV-associated infections, precancers and cancers. There is a 9-valent vaccine that is available for administration, which protects against 9 different strains of the virus, including the ones that cause the most number of cancers, which is viral strain 16 and 18. HPV vaccine is very effective and is safe, as has been proven by previous research. Cervical lesions or precancers in vaccinated women have reduced by 40% when compared to unvaccinated women. Also, analysis of vaccination data that is gathered through the vaccine safety data link has shown that there is no statistically significant risk between getting an HPV vaccine and some pre-specified adverse events like autoimmune diseases or other allergic reactions or anaphylaxis, etc., telling us that this vaccine is extremely safe to be administered. Also, protection for the HPV vaccine lasts for about more than 10 years without any evidence of waning immunity. And WHO has estimated that if we can achieve 90% vaccination rates by 2030, we will be able to reduce cervical cancer incidence by 42% in 2045 globally. Moving on to HPV vaccine recommendations, the current Advisory Committee on Immunization Practices, or ACIP, recommends all adolescents in the age group of 11 to 12 years to get vaccinated against HPV. Vaccination can also begin as early as 9 years. For if the vaccine series is initiated before the 15th birthday, only 2 doses are required. But if it is initiated after the 15th birthday, 3 doses are required. ACIP also recommends catch-up vaccinations for individuals over the age of 15 to up to 26 if they were not adequately vaccinated at younger ages. HPV vaccine is not commonly recommended for individuals over between 27 to 45 years of age. But if the provider feels that they are going to benefit by getting the HPV vaccine, they can opt for it. Also, previous research has shown that HPV vaccination provides the most benefit when it's given to a person who is not exposed to HPV before, so basically before their sexual debut. Also, the immune response that is elicited at 2 doses, which are given at between 9 to 11 years of age, is equivalent to or greater than the immune response, which is elicited at 3 doses given at 16 to 26 years of age. Also, the serum HPV antibody level is known to last longer when the HPV vaccine is given at younger ages, thereby providing longer duration of protection when vaccinated at younger ages. So how does this HPV vaccine uptake look like in the United States? This is the map showing up-to-date HPV vaccination coverage. These up-to-date HPV vaccination coverage is nothing but a measure used to assess series completion. So basically, series completion of 2 doses for people who started the vaccination before their 15th birthday versus 3 doses for people who started after their 15th birthday. The national average is 58.6%, with Mississippi having the lowest up-to-date vaccination coverage at 31.9%. Montana has the up-to-date HPV vaccination coverage in Montana is slightly lower than the national average at 54.4%. But as we can see, we are clearly considerably lagging behind the Healthy People 2030 goal, which recommends 80% coverage. Currently in the United States, Rhode Island is the only state that actually meets these recommendations. And one of the reasons Rhode Island has been able to achieve this milestone is because they have a school entry requirement for HPV vaccine. And currently there are 5 states in the country that have a school entry requirement for HPV vaccine. Montana, as we know, has a school entry requirement for Tdap, but just like other states, doesn't have a requirement for the HPV vaccine. Okay, so before I talk about HPV vaccine uptake rates in Montana, I want to first introduce the concept of missed opportunities. So basically, missed opportunities, if I were to define them, they are clinical encounters when an adolescent walks into the clinic, gets the other recommended adolescent vaccinations like the Tdap, meningococcal, or influenza, but does not get the HPV vaccine. If you clearly look at this graph, we see that the rates of Tdap vaccinations in Montana are much higher than HPV vaccine series completion or initiation rates, thereby signaling missed opportunities. So we know that adolescents are walking in, getting the other vaccinations, but somehow are not getting the HPV vaccine. This is a pattern or a trend that is observed nationally. And in light of this information, the President's Cancer Panel in 2018 cited reducing missed clinical opportunities to recommend and administer the HPV vaccine as a top strategy to improve HPV vaccine uptake both nationally and locally. Also, this is important because low vaccination rates, as we saw earlier, can directly translate to higher cancer burden in the future. So if we tease out these vaccine uptake rates a little further, we see that there is a consistent urban-rural disparity, with rural areas reporting lower vaccine uptake when compared to urban areas. And this is problematic, and because of these, rural communities also face a disproportionate burden of health disparities, including higher incidence and mortality from HPV-associated cancers. In previous research, which was done by Dr. Newcomer and her team, they identified some barriers to vaccine uptake, which are unique to Montana, and they are listed here. Rural areas have limited access to healthcare services. There is higher parental vaccine hesitancy, centering around vaccine safety concerns in rural areas. The misinformation that people receive from the internet, etc., have been cited as barriers. And if we want to eliminate this disparity and improve vaccination coverage, we have to devise some non-traditional strategies which can help to boost uptake. So one effective way to improve vaccination rates is to design and implement novel approaches to engage multiple provider types like nurses for this for this research that I'm doing. A provider's strong recommendation is known to be an influencing factor for parents to decide whether or not to vaccinate their child against HPV. However, most of the research that has been done to understand this vaccine confidence or how providers are conducting vaccine conversations have been targeted at pediatricians and family medicine doctors. There is a lack of research targeting nurses in this area, even though nurses are the primary stakeholders in developing and implementing vaccine promotion activities at their clinic practices. So I feel like tapping into the potential of existing healthcare workforce like nurses and medical assistants who are well positioned and also possess the skills to conduct these vaccine conversations with parents or patients, and harnessing their expertise in engaging them in these vaccine conversations can definitely help to improve HPV vaccine uptake in states like Montana. Also, again, in previous research, limited time for vaccine discussions and greater informational needs by parents regarding HPV vaccination has been identified by some providers as a barrier to recommending the HPV vaccine to parents. Nurses can help bridge this gap and emerge as HPV vaccine champions. There is also a relative shortage of pediatricians and family medicine doctors in rural areas. And in largely rural states like Montana, nurses are the sole providers in some communities. However, in previous research, non-physician health providers like nurses have expressed less familiarity with HPV recommendations, which could discourage them from providing strong and effective recommendations. So if we want to develop evidence-based interventions to engage this professional group, it becomes imperative that we understand their knowledge, attitudes, and current professional practices regarding the HPV vaccination. And nationally, the HPV Vaccination Roundtable has also identified engaging other providers like nurses and medical assistants as a top priority to fill the gap in HPV vaccine delivery research, which is aimed at improving vaccine uptake. So with this background information, in consideration of the background information that I just presented, these are my dissertation aims. My aim 1 is targeted at determining the role of nurses and medical assistants in promoting HPV vaccination in Montana. And I'm conducting a statewide survey to do so. My aim 2 talks about identifying nurse and clinic level facilitators of HPV vaccination in rural public health departments in Montana. And I'm going to use qualitative research methods like interviews or field visits to collect my data. And my aim 3 is focused on identifying county level socio-demographic and access to care factors that are associated with missed opportunities for HPV vaccination in Montana. And I'm going to conduct a quantitative analysis of the IIS, which is Immunization Information Systems data. So starting with my aim 1, we got a subcontract from the Montana State Public Health Department to conduct a cross-sectional survey of nurses and medical assistants that are working in Montana at clinics that participate in the VFC program. So VFC program is basically a federal program called Vaccine for Children program, which provides vaccination to enrolled providers for them to then provide these vaccinations to eligible children for free of cost. We developed an online survey using RedCap and containing questions that investigated nurses' experiences with recommending adolescent vaccinations, their general vaccine attitudes and perceptions, what are the current practices in place at their clinics, and also what strategies do they think would work to increase the HPV vaccination rates. These survey questions were adopted from previous CDC-funded surveys on primary care providers and also some existing literature on this topic. So after we finalized the first draft of our survey, we sought internal feedback on the questions from professionals within our department at the University of Montana. This was followed by conducting cognitive interviews with a total of 7 nurses and medical assistants. So basically, cognitive interviews are used to examine if the questions are interpreted in the same way as we intend, as their intended meanings. So basically, we ask the nurses to give us an account of what they are thinking while reading a question, or while responding the question, or just after responding the question, just to understand if there are any ambiguities in the question or in the interpretations of questions, and then also ask them probing questions on their thought process wherever appropriate. So basically, using these cognitive interviews, we sought their feedback on, as I said, interpretation of questions, if there are any ambiguities on the survey design, how the survey was flowing, or any other additional comments that they would like to provide. After the final survey draft was ready, we sent out an email containing the study information and the online link to take the survey to VFC administrators across all facilities and asked them to further distribute it to the nurses and medical assistants working at their facilities. We sent these emails to about 446 unique email addresses at 248 unique clinics all across the state of Montana. And we also sent about 2 email reminders at an interval of 1 month after the first email was sent. So the final draft of survey had survey questions, which are broadly divided into 5 sections. These sections had questions that were targeted at understanding, which first started by asking them about their nursing credentials, and also about what exactly are the responsibilities at the clinics that they work at. This was followed by asking them questions on what routine immunizations they provide to adolescents at their clinics, about reminder recall systems. We also asked them questions about parental awareness, acceptance, or refusal of HPV vaccines, also the barriers they think, also the barriers to HPV vaccine uptake. This was followed by asking them what strategies do they think would help to increase immunization rates in Montana, and lastly, some demographic questions. So we received a total of 309 responses, incomplete and complete. 296 participants did provide their consent to answer the questions, and about 270 respondents met all the eligibility criteria, basically working as a nurse or MA or a medical assistant in Montana and being involved with immunization services for adolescents. So now I'm going to share some findings. These are overall findings that we got. I'm still in the phase of working on my manuscript, so these are just raw numbers that I'm going to show right now to you. Starting with the nursing credentials, about 57% of our respondents were registered nurses, followed by 24% who were medical assistants and 17% who were licensed practice nurse or LPNs. About 23% of our respondents worked at a community health center. About 29% worked at other clinic settings like tribal health facility or a school-based clinic or a rural health clinic. About 20% worked at private hospital-based clinic, 19% at a public health department, and 9% at an independent private clinic. Talking about health planning regions, most of our respondents, about 34.2%, were from health planning region 5. So for a question on what adolescent vaccinations nurses offered at their clinics, most of the nurses responded offering all recommended adolescent immunizations at their clinics. However, fewer nurses reported offering HPV vaccination for younger age group or for the age group of 9 to 10-year-old patients. And this is an important finding. I'll talk about this in my upcoming slides about why is it important. For nurses' beliefs and current HPV vaccination practices, most of the nurses responded having confidence in the safety of the vaccine and showed support for the HPV vaccine. They said that it is important. They think that it is important for adolescents to be vaccinated before their sexual debut to be adequately protected. However, about a little over 33% nurses did report anticipating an uncomfortable conversation when discussing HPV vaccination with their patients or parents. Also, about 70% nurses did feel that HPV vaccine has more resistance when compared to acceptance of HPV vaccine has more resistance when compared to Tdap vaccine because it is not required for school attendance. So for nurses' perceived barriers to HPV vaccination, the top 3 barriers I've marked them here. As we can see, most of them are focused on parental vaccine hesitancy. So basically the top barrier being misinformation that parents receive from the internet that deter them from getting their child vaccinated against HPV. Also, parents thinking that the vaccine is not necessary for their sons, or they have some concerns about the safety of the vaccine. So based on the findings from this graph, we can see that nurses reported that parental refusal or deferral of the HPV vaccine was more common in younger ages. This is an important finding and is problematic because, as I spoke earlier, it is very important that adolescents be vaccinated in time to be protected against HPV-related infections or before they indulge in any kind of sexual activity. Also, of note, there has been a push by the American Academy of Pediatrics for providers to start vaccinating individuals at 9 years of age. Actually, providing this vaccination at 9 years does provide some benefits. Number one being it provides the providers with more flexibility to introduce the HPV vaccine. They can also steer the conversation away from sex talk to just talking about cancer prevention while talking to the parents of 9 to 10-year-olds. Also, for parents, it is more preferred to get their children vaccinated between 9 to 10 years of age so that they can avoid having their adolescents get concomitant vaccination or 3 or 4 vaccinations in one sitting during the 11 to 12-year-old well-child visit. Also, one vaccine that's most commonly deferred during well-child visits is the HPV vaccine, and that's why it's important to get done with the series before adolescents get due for other adolescent immunizations. In a retrospective analysis of data, it has also shown that adolescents who initiate the HPV vaccine series between 9 to 10 years of age are 22 times more likely to complete the series by the time they turn 15 years, as opposed to adolescents who start their HPV vaccination series between 11 to 12 years of age. So moving on to questions on reminder recall systems. Basically, reminder messages are messages that alert patients on vaccinations that they will be due in the future. And recall messages inform patients about vaccines that they are already overdue for. Reminder recall efforts could be conducted through phone calls, emails, postcards, etc. And they have known to be evidence-based strategies to improve vaccination rates. Also, using reminder recalls have improved the proportion of adolescents who receive timely immunizations by roughly 7 percentage points, as reported by in a previous study. So we did ask respondents some reminder recall based questions. About a little over 50% nurses did report using some form of reminder recall systems. However, about 28% did tell us that, how frequently they use these reminder recall systems or how frequently they create these lists depends on whether they have the staff capacity to do so or not. Also, about 30% of the nurses told us that, reported in the survey, that they ask parents to proactively contact them later to return for additional vaccine doses, which could also be a contributing factor to lower series completion rates. So this was the last question. We asked nurses about their supportive strategies to improve HPV vaccination rates. And I've marked the top 3 strategies that were identified by the nurses, emphasizing cancer prevention being the number 1. And nurses also supported partnerships with schools or community organizations to educate parents and guardians about HPV vaccination. So to conclude, our study findings did point out some strong initiatives to engage this provider group in improving HPV vaccination rates in Montana. On the provider level, training nurses to provide strong and effective recommendations would help to improve HPV vaccination. Some of these approaches have been used with primary care providers successfully, like using presumptive versus conversational approach. So basically, presumptive approach is where providers start the conversation about HPV vaccination by telling the parents that, not by telling the parents that, do you want to consider the HPV vaccine? Instead, telling them that your child is due for Tdap, meningococcal, and HPV vaccine, which protects him or her against a variety of diseases, including cancer. So just assuming that parents have an intent to vaccinate their child against HPV. Motivational interviewing is another technique that has been tested successfully among providers, and it basically is built on the premise that providers should not dismiss parents who do not intend to vaccinate their child or have questions about vaccination. Instead, they should be empathetic towards the parents. They should listen to their concerns and try to answer any concern. Listen to their concerns and try to answer any questions about vaccines that these parents might have. Also, ask permission before providing any vaccine-related information. Also, some other approaches would for training nurses would be on how to steer the conversation away from sexually transmitted disease prevention and focus on cancer prevention. Previous research has also shown that parents do revisit their vaccine decisions frequently. So revisiting HPV vaccine at every clinic visit would also encourage parents to consider vaccinating their child against HPV. At the clinic level, providing support to these facilities for implementing reminder recall systems, also helping set up centralized reminder recall efforts by state or county health departments to let adolescents know that they have to return back for their vaccines or what vaccines they are due for. And at the patient level, just increasing opportunities to provide patients with vaccine-related information. For example, outreach to emphasize on the gender-neutral nature of the vaccine. So basically, just letting the parents know that this vaccine is important for their sons as much as it is for their daughters, and also improving access to scientific information. Using vaccine information sheets at provider's office or showing educational videos while parents or patients are waiting for their provider visit in the waiting room. Okay, so this concludes my aim 1. For my aim 2, as I said previously, I'm going to work on a study that's focused on identifying nurse and clinic level facilitators of HPV vaccination in rural public health departments in Montana. For this study, I'm going to use something called as the positive deviance approach. And this approach is built on the premise that knowledge about what works is already available in existing organizations that demonstrate exceptional performance for a certain standard. This approach is, and this is very common, the positive deviance approach is very commonly used in health services research. And it's particularly appropriate in situations where you can rank organizations reliably based on valid performance measures. For this study, the performance measure that I'm going to look at is missed opportunities. There is a substantial variation in performance within an industry. There is also an openness to talk about practices that help these organizations achieve this exceptional performance. And also there is an engaged constituency by potential stakeholders to promote uptake of these evidence-based practices. Positive Deviance approach also emphasizes on developing strategies that rely locally on resources that already exist in the community to facilitate wider adoption and sustained use. So for my study, I'm going to work on step 1 and step 2, basically identifying public health departments that have high and low missed opportunities to vaccinate against HPV, and then study these departments using qualitative research methods, which is in-depth interviews and field visits to understand what are these evidence-based practices that help in higher vaccination rates in some public health departments versus others. So there are two main reasons I decided to work with public health departments. I recently co-authored a study with Dr. Newcomer, where we found that missed opportunities to vaccinate against HPV were highest among the public health departments when compared to other clinic settings. In fact, adolescents who visit a public health department to get their vaccinations are 25% more likely to not get the HPV vaccine when compared to adolescents who visit private clinics for their immunization needs. Also, in rural states like Montana, adolescents are most likely to visit public health departments to get their vaccinations, and therefore public health nurses play a major role in HPV vaccine delivery systems. The National Advisory Committee, Vaccine Advisory Committee, has emphasized the need to address barriers to vaccination in venues outside of traditional primary care provider offices, including public health departments, in our efforts to increase HPV vaccination rates. And while there are studies that have looked at characteristics of primary care clinics in terms of how they are delivering the HPV vaccine, there is very little research done on public health departments. Public health departments are different from primary care clinics in terms of the autonomy they enjoy, the governmental oversight that they're subjected to, the funding they get, the staffing issues that they face, etc. And most prominently, while primary care clinics have a distinct target population to target their reminder recall efforts, public health departments are mostly open for walk-in appointments and are only used for episodic care like vaccinations. Therefore, this restricts their ability to go ahead and do these reminder recall efforts and ask the patients who are overdue for vaccinations to come to the clinic and get their vaccines. So this is a flowchart that gives a high-level overview of my study methods. Basically, we are done with quantifying missed opportunities to vaccinate against HPV for these 51 rural public health departments. What I'm going to do is next is I will rank order these public health departments from highest to lowest proportions of missed opportunities, and then I'm going to stratify them into quartiles. The study sample will come from the top and bottom quartiles. So basically, low performing public health departments with higher missed opportunities to vaccinate against HPV, and high performing public health departments with lower proportion of missed opportunities to vaccinate against HPV. I will recruit 10 immunizations from each top and bottom quartile, so a total of 20 immunization nurses to conduct qualitative interviews. And this will be followed by conducting field visits at a total of 6 public health departments. So as I said, data collection will be accomplished using surveys, in-depth interviews, and field visits to identify provider, patient, and practice level barriers and facilitators of HPV vaccine promotion at these clinics. As Dr. Newcomer mentioned in the introduction, I did receive a fellowship to do this work and present it in New York in August. I also received a sub-award from the CDC through the State Health Department. I have also listed some example interview questions here on the slide for your reference. So my last study is more of an environmental scan to identify county level socio-demographic and access to care factors, which are associated with this missed opportunities to vaccinate against HPV in Montana. And this graph is from a study that we recently did. As you can see, the proportion of missed opportunities have a really wide range for different counties in Montana. And if we want to ensure optimum allocation of limited health resources and inform geographically targeted intervention, it's very important that we understand what are the factors that is driving this variation in missed opportunities. So my third study is focused on that. I will be looking at about 10 to 15 county level socio-demographic and access to care factors, but in the interest of time, I have just included 2 of them here. I'll use a generalized linear mixed model with binomial distribution and log link to conduct the to do the model building. The dependent variable is whether a clinic visit was a missed opportunity or not, and the independent variable is county level density of nurses. This model also accommodates, I'll also accommodate random effects and fixed effects during model building. So this is my dissertation timeline with the proposed graduation date in May of 2023. So I'm hopeful that the data collection for AIM2 will be done by summer, and AIM3 would be completed by the end of this year. In addition to working on my independent dissertation, I am also involved with a lot of vaccine-related projects through Team Vaccine. I have listed some publications that I've been a part of, including some current projects that I'm involved with. And last but not the least, I would like to acknowledge the support of my advisor, Dr. Sophia Newcomer, and my PhD committee members, Dr. Ward, Dr. Languth, Dr. Karinji, and Dr. Alison Young. I would also like to thank Dr. Amra Suleiman, who is the CEASE investigator, the fellowship that I just received to work on my research AIM2. I would like to thank my Team Vaccine and PhD colleagues for their support and input. I would also like to thank the Center for Population Health Research and Montana State Health Department for funding and supporting my dissertation research. And my contact information is here. These are the references. Thank you so much. And with that, I'm open for questions.
Great job, Juthika. Lots of Zoom hand claps going on. So invite people to come over the line with questions or type in the chat.
Go ahead.
No, please.
Okay, thank you. Juthika, great job. Really, really nice start to all of this work. My question, you had a slide where you talked about kind of your implementation plan, and it was about the nurses changing the conversation. It was about reminder phone calls, and then it was patient level. I'm curious, of those 3, do you have any thoughts on what might be the most successful or the most impactful based on your experience with clinical care or some of the other work that's been done?
Sure. So for the interventions that I spoke about, right now there is ample data on the one approach where I spoke about presumptive approach versus conversational. I think in one of the studies, so this has been tried and tested by providers for different vaccinations, so early childhood vaccinations and adolescent vaccinations, etc. And there has been an increase of 5.4% in the vaccination rates at clinics where providers used a conversational approach versus where they used presumptive approach versus conversational approach. So there has been evidence for that. When it comes to providing, like increasing outreach for parents, there are studies that have looked at that. It's not on the top of my head, but I do remember a researcher talking about whether showing videos of how cervical cancer lesions look like would actually work or influence parents to get the vaccine for their child or not. I still need to look at whether this study was done already or whether the results are out. But I do remember that there is a group of researchers looking at that. So HPV vaccine has been a topic of a lot of research out there. And yeah, so with this motivational interviewing and things like that, yeah, I know that they have worked. And using those strategies and training nurses to promote the vaccine or recommend the vaccine in similar ways would definitely help in improving the vaccination coverage.
Thank you.
Yeah. And also the way to give more information on the question that you asked, also previous research has also shown that how a provider initiates the vaccine conversation and how strongly they recommend the vaccine does positively influence the parents' acceptance of the vaccine or the parents' decision to vaccinate or not. So, yeah.
Yeah, I think my other thought on that was we've done some motivational interviewing stuff in physical therapy, and it's great, but it's more time consuming. And so I'm just thinking about feasibility of those options. And so maybe you're on the right track there, that presenting it differently might be the better option.
Yeah. So I recently read a study where there was this quote from a provider. I think the study was about collected data through qualitative interviews from providers about their HPV vaccine strategies to recommend them to the patients. And one of the providers did say that, you know what, I just don't, so if a parent tells me, oh, I don't want to vaccinate my child, I don't stop there. Every time they come in, I do tell them that, you know, I am going to keep talking about this until you decide to get your child vaccinated. So I think that is one strategy that providers can really use by not dismissing parents saying, okay, they probably don't want to, but keep on reinforcing the importance of HPV vaccine can also help.
I'll jump in. Juthika, thank you for your presentation. Very, very interesting work. I was wondering if you could expand upon, you were talking about vaccine hesitancy for the HPV vaccine. And of course, vaccine hesitancy is a very, very important sort of issue. And you mentioned that the internet and social media were a very kind of important component to understanding hesitancy in this domain you're working in. And I was hoping if you could maybe expand upon that a little bit, you know, what kinds of messages or issues or ideas there are out there in social media and the internet domain that you think contribute to vaccine hesitancy?
So I'll give you an example from India. There was a trial that was happening for HPV vaccine. And I think in that cohort of participants who got the HPV vaccine, 7 girls died. So there was a misconception that was spread that it was because of the vaccine that these girls died, whereas you cannot really so in clinical research, basically we are trained to report all adverse events, whether they are associated with the drug or the vaccine or not. So basically there was a message that was spread that the HPV vaccine causes death, which is not true. And we know that from the continuous surveillance data that we have, not just for HPV vaccine, but also for other vaccines. So misinformation in terms of a lot of parental vaccine hesitancy. Basically, a lot of parents think that, if they get their child vaccinated against HPV, that might that might send out a message for them to engage in sexual activities. So that's why they're hesitant, because when HPV vaccine was introduced in the market, it was called it was a vaccine that prevented sexually transmitted diseases. So that's why now there is a push to move away from calling it a vaccine that prevents STDs to vaccine that prevents cancer. So that is one reason why parents would hesitate. And then other is parents just say that, I don't think my child needs this vaccine because they don't engage in any physical activity. So that's any sexual activity, I'm sorry. So that's another reason parents don't get their child vaccinated against HPV. Another reason is that when parents bring their children to get vaccinated, usually they so for this well child visit, they get 3 different vaccinations, and if it's flu season, there are 4 vaccines. So if child says, no, I don't want to take so many vaccines, parents are like, okay, we'll come back again and get the HPV vaccine later, which usually they don't come back. So that's another reason why vaccination rates are lower. And misinformation from social media, what I have heard is that there is information on the fact that there is a misinformation floating around which says HPV vaccine causes fertility issues and things like that, so which is not true. So, and all this actually influences parental decisions to vaccinate their child.
Thank you.
Yeah.
Juthika, I'm going to read a question from the chat from Emily. Do you expect the current workforce shortages in public health to impact whether HPV vaccination efforts are prioritized among health departments? Or have you heard any feedback on this from state or local health departments?
Emily, to answer your question, one area where I think there is an impact of provider shortages is doing reminder recall efforts. So a lot of nurses did support having the state health department to conduct these centralized reminder recall systems. So and there have been, and research has shown that reminder recall efforts, when done at clinic levels, tend to fail, even though the practices do get the funding and technical assistance to do so. And so in such scenarios, it's better to have centralized reminder recall systems. So yes, I do feel like the current shortages will impact the HPV vaccine promotion. And but I haven't heard any feedback from this from the state or local health departments. All I can think of is the reminder recall. Most of the nurses are supportive and want to give HPV vaccinations to adolescents. So the only area where we can work on to improve vaccination rates would be supporting them with centralized reminder recall systems.
I think that's a really interesting question. And I think it's actually going to be very timely that the survey you led was done kind of right at the beginning of the pandemic, before we had a lot of workforce declines in public health. But then this work that you're doing this summer with AIM2, I think you might be able to maybe, like in the fall, answer Emily's questions a little better, because you'll be talking with several public health departments. So thank you, Emily.
Yeah, no, thanks. It's really interesting. I hadn't heard that about the centralized recalls, so that's also really interesting, and probably a really effective way to streamline and make things more efficient for our different providers around the state. This is awesome, Juthika. Thank you.
Thank you.
All right, we are right at stopping time. So I just want to thank and congratulate Juthika on the work that she's done to develop this dissertation. And invite anyone, if you have additional questions that you didn't get to ask today, Juthika provided her email address, so you're always welcome to reach out to her. But thank you, everyone, and have a great afternoon.
Thank you. Thank you, Dr. Ward. Thank you.